Good afternoon, everyone. We are really excited for today's discussion. It's going to be about a million-dollar topic, behaviors. And I know behaviors impact each of us all day, every day. I'm a mom of 3. One of my children has Duchenne. And by trade, I am a counselor. So I've worked through many different, my own children's behaviors as well as other people's. And it's a huge part of our life. And we're so excited today. We have a very esteemed panel here that are going to speak with us. We have Dr. Natalie Truba, who's going to talk to us and highlight the effects that Duchenne have on the brain. Dr. Colvin is here, and she's going to help us understand when more support and interventions need to be made. Jill Castle is here, and she is going to provide us with her fabulous formula for discovering the function of the brain. And Denise Gruender is also here, and she's going to give us practical tips and tools that we can work into our everyday lives and see how we can get through these behaviors, which can be trying, they can be great, they can be up, they can be down. And I don't want to take up too much time because we have a lot to go through, but with that said, I'm going to ask Dr. Truba to come on up and get us started.
Thank you. Hi, I'm Natalie. I'm a pediatric psychologist at a Nationwide Children's Hospital in Columbus. I am very excited to be here today to talk about something I'm very passionate about, which is understanding the brain and how dystrophin protein impacts the brain and brain functioning, particularly related to emotion and behavioral regulation and sort of quality of life and well-being. I'm going to talk very quick because I'm trying to go through a lot of information in a short period of time, so please just come chat with me or find me after this if you want to talk more, so I could talk about this for hours. So we know that there are multiple dystrophin isoforms expressed in the brain that have really important roles, and so we've spent a lot of time in the last 30 years plus talking a lot about DP427, which is muscle protein. But DP427 is also expressed in the brain, and it has a pretty big role in GABAergic sort of organization around the postsynaptic spaces, similar sort of to how it helps organize within muscle protein. And that's important because GABAergic neurotransmitter processes are regulatory in that they help kind of calm aspects of synaptic functioning in a lot of ways. DP140 is another dystrophin isoform that is not expressed in muscle. These last several are only expressed in the brain. And so DP140 is very involved in prenatal brain development, and so it's something that is highly expressed prenatally, but then sort of drops off a lot in healthy adults or adults without dystrophinopathy. There's some relationship between lacking DP140 and having more of an autism-like presentation. DP71 is the most abundant dystrophin isoform expressed in the brain. It is very involved in glutamatergic sort of processes. Glutamate is an excitatory neurotransmitter, and it kind of not producing DP71 seems to sort of create like a hyperexcitability or an overexcitability in the brain. And what's really cool about DP71 is it also is involved in astrocyte cell function, and astrocytes are a cell in our brain and elsewhere that help actually clean up excess glutamate. So they're kind of double whammied from a glutamate standpoint. And then there's a very unique, smaller group of men and boys who are lacking both DP71 and DP40. And there's some concern that can at times change the cerebral blood flow to the brain. And so if you're not getting good blood flow to the brain, then you can lose brain volume or have some negative impacts just not having good oxygenation. So there's a lot going on in the brain, right? So not only do we need to understand our muscle proteins and what's going on there, but there's all these other dystrophin isoproteins that are very important. On top of that, so we know there's multiple isoform or proteins expressed in the brain. We also know dystrophin is expressed differentially in that it's expressed in higher amounts in different parts of the brain or different structures. And we see this not only in our boys and our men post-mortem, but also in our MDX mice. And so what is really important is understanding that dystrophin expression is very high in the hippocampus and the amygdala, but lower in the cerebellum and the pons in healthy adults, right? So this tells us that dystrophin is protein, and I'm not somebody that has Duchenne or Becker, obviously, and these are important proteins for my brain as well, right? So what this tells us is that not making dystrophin in these areas has some probably pretty big effects, which is what we see in our kiddos. The hippocampus plays a huge role in memory and learning, but also is really interactive with the amygdala, which is a part of our brain that helps with emotion processing. On top of that, it also really involved the amygdala in processing and retaining and sort of making sense of memories that are related to survival. So fear, anxiety, things like that. So our flight response, sort of social behavioral recognition and sort of understanding or being able to quickly just, unconsciously decode nonverbal facial expressions and things that happen very quick for humans. And something called reward processing, which is how is it received or internally, processed around from an emotional significance standpoint in relation to a consequence, whether that's a reward or punishment. So might be a lot of people here have kids, I imagine, and you might notice like one of my kids really doesn't do well to this form of punishment and the other one does, right? So we'd say this is much more, has a higher weight from an emotional valence standpoint for this kid than that. We want to rely more on those motivators than maybe for this other kid. And so that's really important to understand because these are happening in utero and then actually as we develop. So these kiddos are born in a world where they're already kind of a leg down, and how do we regulate? We see this in our MDX mouse. Our MDX mice that are lacking DP427 alone have heightened fear conditioning. They have a much more exaggerated startle response. So mice, when there's a stress response, they just freeze. Humans, we fight, flight, freeze, or appease, so we're much more complicated beings. But they take a lot longer to sort of get their little whiskers get going and get back to exploring the cage than wild-type mice. When we then add in additional deletions or additional voiding of certain DP proteins in the brain, we see even more anxiety, and we see even a more robust heightened startle response, fear response, that lasts even longer. This is also consistent with some of the data coming out of the UK, but in our boys, we also see that they have an increased startle response, and they take longer to calm down after a startle response, likely related to that deficiency of dystrophin in the limbic structures. They also have a hard time with quickly, and not everybody, but quickly sort of understanding and weighting social stimulus when it comes to facial expressions or other things. So they are often misperceiving, right, neutral stimulus and or positive stimulus as potential threats. So you might have a neutral face, and some of us have what we would say like RBF. I'm gonna assume everyone knows what I mean there. They might perceive that means you're mad at them, right? And so now we have kiddos they're in their brain perceiving something that's making them feel a type of way, which then increases our motivation to do certain things like avoid or shut down or feel anxious or lean into that or not check our thoughts. So this is really important because the brain is a very complex organ system. It just is. We have a lot of complicated organ systems in our body that we understand really well. The brain is not one of them, but we know a lot more about the brain than we used to. But human behavior is also very complex, right? We try to make it simplified. We're like, oh, it's super, if you're a human, you're behaving, you should just know how to do that. Not true. It's very challenging. And this is because all behavior serves a function. All behavior is purposeful, even if it's maladaptive. So hitting, maladaptive behavior, but effective if me hitting you makes you stop putting a demand on me. We don't want it. So it's maladaptive, but effective. So there's no behavior, there's no kid in your life, if you're like, I don't know why they do this nonsense, it makes no sense, there's no reason they do that. I guarantee you there is a reason they do it. You may not make sense to you, but there is. We don't behave for no reason. So understanding that function is so important because it's more important understanding that than a topography or what a behavior looks like. This is where we get bogged down. We're like, no, we're crashing here, we're loud, we're doing this, this behavior, they're impulsive, here. That's good to know, but we don't want to take that constellation of behaviors we can see and say, okay, that means you have this, let's treat this. Because we know that they have dystrophinopathy, right? So we want to say, okay, what are these behaviors serving the function for you, knowing what I just reviewed about the brain? And we go from there around how do we think about treatments and other things, and Jill will talk much more about the function here in a second. But yes, thank you all so much. Would love to talk for hours about this with any of you if you're up for it.
Thank you, Dr. Truba. I love that you said that the brain is a complex organ and behaviors are complex. So if anybody sitting out here wanted to take this back and go back to their clinic or after they're talking with you, how would you recommend they go about initiating that without saying, hey, something wrong with the brain? But what would you recommend?
I would probably encourage going and saying, I went to PPMD, wonderful conference, amazing people, and I learned that there's multiple dystrophin isoforms expressed in the brain, and we only ever really talk about DP427, which is muscle protein. Do you have somebody that can help me better understand that, and how do I think about this for my kid? And they're probably gonna be like, no. And you say, well, that sounds like a gap in care here, my friends. We should work on that.
Thank you so much. We appreciate it. Now we're going to hear from Dr. Molly Colvin.
Hi, I had the longest walk, and I have a very hard act to follow, which is Dr. Truba, who can walk us through brain in 7 minutes. It's amazing. So knowing this information, I think what I want to do now is sort of say, okay, well, how do we bring this into the clinic? How do we sort of, now knowing that dystrophin is expressed in different ways in the brain and it may have an impact on behavior and learning and social function, now what do we do about this? So I want to talk about when clinical assessments may be needed. So this is the part that Natalie just covered, and way better than I would. But the takeaway here again is that over the course of development, we need to be monitoring brain functioning. And the way that we often do that is by looking at different aspects of behavior. So how this often manifests is that we know that for many who have dystrophinopathy, that they sort of have typical cognitive functioning, typical sort of social and emotional functioning, but we also know that there's an increased risk of neurodevelopmental conditions. And this laundry list, which I sometimes call the alphabet soup, are things that children can have in isolation, but they can also have multiples of. So you can also see a child who has both a language and a speech delay, and they have ADHD. They can have a learning disorder, and they can have autism spectrum disorder. And so sometimes when kids come to see me who have dystrophinopathy for a neuropsychological evaluation, I wind up sort of feeling like I have to you leave with a whole alphabet soup of other diagnoses that have kind of gone along with this to describe what is probably a single kind of condition, a neurodevelopmental condition that's associated with dystrophinopathy. The most important piece, though, is not to remember all of these different diagnoses and to wonder whether your child has all of these different diagnoses. It's actually to think about their behavior, sort of what Dr. Truba was telling us, to think about the different domains of behavior, and specifically to break this out into what we have been thinking about as behavior, emotions, learning, and social skills. And the acronym that we've been using, Dr. Truba and I, has been BELLS around this. So we actually have designed a questionnaire that we're piloting, and PPMD has been a huge supporter of, that is going to hopefully help us to kind of identify kids who may have some of these neurodevelopmental concerns that warrant further intervention and assessment. And so we're going to make a little bit of a plug here to look in the fall for a blast that comes out for PPMD to ask all of you if you might participate in that questionnaire and validate it so that we can actually have a unified measure that would help to screen for this and help people be recognized earlier so that we can intervene earlier. Because one of the things that we know is happening right now is that you guys, when you go and you're managing the medical piece, you're interfacing primarily with the neuromuscular clinic and the pediatrician. But there may not be room in those visits to sort of talk about all of these other things that may need a recommendation for psychiatry, for medication, for anxiety or OCD behaviors, or psychotherapy for sort of tantrums or outbursts, or specialized evaluations that may lead to a diagnosis of a learning disability, or how do you talk about school and community resources. Those are things that often Natalie and I will wind up doing in our institutions, but we need to know who needs to come see us because there aren't enough of us to go around too. And so what we're hoping is that the BELLS questionnaire will help to kind of facilitate those referrals faster. I'm going to run through in the last few minutes here who some of these specialists might be, who you might see if there are any of these kinds of concerns. There are child psychologists and child psychiatrists. Psychologists, the quick and dirty on this is that psychologists often do sort of therapy, psychiatrists often do medication. That's quick and dirty and not perfect, but that is sort of the way you can sort of think about it. Neuropsychologists like me, I'm a psychologist, but I do assessment, and so I often get called in a little like as a consultant to make differential diagnosis. There are speech and language pathologists. There are also, as you all know, OTs and PTs. And then for some kids, ABA is appropriate if there are autism spectrum symptoms. In terms of where you get help, the public school system is sort of a wealth of information and resources, and so early intervention services, or EI, is covered from birth to age 2 by federal legislation in the United States. When you get to age 3, from 3 to 5, you go to early childhood special education services, and then after that, it's going to be either a Section 504 or an IEP plan. Major difference between those two is both of them can do accommodations, but IEP should be doing services. So if you have OT, PT, speech and language, any academic services, then you really should be on an IEP as opposed to a 504. And there are some key guiding principles that really determine around placement. This comes out of the civil rights movement and sort of making sure that everybody has a right to a free and appropriate public education in the least restrictive environment, and that things may change over time, and so these plans need to be updated. The eligibility is not usually determined by a medical diagnosis, nor is it determined by somebody like me, a psychologist or a neuropsychologist who sees you in the medical setting. It's determined by the school, and they have their own process to sort of do this. But they may interact with the medical providers, and it's really important that you sort of have people who know the system and can help you interface with it. The kinds of school services, this is a long list of them, but they can all be ones that you can obtain within the school, and these can supplement and even augment services that are being provided in the medical facility, especially for those of you who have to travel a long way to find your medical care. The source of the school system can actually be a really helpful use and provision of services. What are some of the benefits of early intervention? I mean, I think, one of the things that we really feel most strongly about is this idea that we don't want behavioral and emotional and learning concerns and social skills concerns to go untreated. These are things that over time have a really big impact on self-efficacy, on how you feel about yourself, on sort of school success and social integration and family functioning. And many of these things we know how to treat. We know how to treat sort of attentional issues. We know how to treat anxiety. We know how to treat social skills difficulties. We know how to treat dyslexia and dysgraphia. These are things that we can do that will significantly improve functioning. And so it's really important to be thinking about the whole child nested within their different domains of functioning, their family, their peers, their school, and their community, and to help find psychosocial resources and supports that will make a difference in terms of overall quality of life and development. Thank you.
That bell system, I think, is going to be so advantageous across the board when we go into our neuromuscular clinics and we can have a checklist. And I just think moving forward, the help we can get children just from that is going to be monumental. So thank you for that. I bet there's people sitting in this room right now that have just taken a deep breath after listening to you, Dr. Colvin, and saying, okay, yes, that's what I need to do. That's where I need to go. I need to get started. So what would you recommend, just if they remember anything, what would be step one?
Okay. I think the first is there are probably a couple things. I think first, to not be afraid to raise it with your pediatrician or your neuromuscular specialist. I think PPMD has done a really great job of helping to kind of inform the community. There's some really great resources about this on the website in terms of educating, just so that they have a sense that they're not totally caught off guard when you raise it. I think the second is to lean on some of those community supports, and starting with the public school system. So even if your child is in a private school or homeschooled, they can still be eligible for special education services through the public school system. And so starting with an evaluation to even just determine eligibility, and then sort of kind of wrapping in some of those supports from the medical center if you live close enough to also have those as well.
Wonderful. Thank you for reiterating. And next up, we have Jill Castle. So she's going to come on. Yep, you're up.
Okay. Hi, I'm Jill Castle. I put behavior formula because it was the easiest way to talk about what I'm going to talk about. We're going to shift gears a little bit. My academic background is educational psychology with an emphasis in behavioral analysis. So I look at this a little bit different, and I also have a son who is almost 26, and so I'm also a parent as well. So if there's anything that anybody can leave, the mission of my talk today is to think about the function of behavior. Dr. Truba mentioned it. In my world, for behavioral analysis, it's the most important part because everybody, all of us, behavior is just communication. That's all it is. We're just trying to communicate something. It's not necessarily good or bad. It's just trying to communicate something. And I think I know as a parent personally, I was so busy taking things personal that I could never stop and just look for the function of the behavior. So that's what I really wanted to stress today, is if we can somehow, by some miracle, take ourselves out of it and just look at it scientifically, what the function is, it makes it a lot easier to kind of manipulate the environment to extinguish a behavior that's not working for everybody. So there's 4 functions that our kiddos are doing things for. We all do things for. It's either to escape something, to gain something, get attention, gain something tangible, or sensory. I'll give a timeout example. That's my favorite example to explain why the function matters. So you give your kiddo a timeout because he's bothering everybody and trying to get attention, and so you let him take a few minutes away from the attention that he's getting. That could possibly be a solution that might help. But if he's throwing a fit because he's trying to escape work or a demand that you're putting on him, and you give him a timeout or a teacher takes him out of the room, you've now just rewarded it and the behavior's gonna get worse. So that's my example of why it's so important to understand why the behavior's happening. And this works for young kids and adults and our older young adults. So an example of function that I made to make this simple is Jordan has a meltdown in class or at home. Why is he upset? Okay, maybe he's trying to escape or get out of work or a demand that he doesn't like that you're putting on him. Maybe he's trying to get attention. I changed that word to connection because somewhere along the line, when we say that kid's just trying to get attention, especially in school, it becomes this very negative connotation, right? Maybe they're trying to get connection. So maybe that's not so negative if we look at it that way. But either way, it's maladaptive, it's not working, right? And so they're trying to get attention. He could be upset because he's trying to get an item or an activity or something that he tangibly wants, or his system is out of sorts, which could be sensory. So the solutions are going to vary. If he's trying to escape a task, you maybe want to break the tasks into steps or have him do smaller portions at a time and have him build on that tolerance a little bit at a time, and then that might help. Just like some of us who don't want to do our work, we might just do a little piece of it and get a little reward and then go back and do a little bit more, and that's how we break up a monotonous task that we're being forced to do that we don't want to do. The second is attention. Build in sustained attention with him and interaction and connection with him, allowing him to lead the interaction as a reward for a more appropriate response. Tangible, he wants to use an item or an activity. You use that item, whatever it is that he's looking for or wants, that's your power. That's what he wants. So we just use that. Sure, you can have that after you do this, or once we get to this place, then you can have that. So it kind of gives you a built-in reward system. And then the sensory is teaching self-soothing. That's really tough because a lot of our guys, as it was explained, have trouble regulating and they're dysregulated. And so it's kind of hard because if you can't look at the function and go, okay, he's not trying to escape anything, I'm not putting any demands on him, and he's not necessarily trying to get my connection or get something or gain an item, he's just out of sorts. And the way that we test this, like in the school environment, is that if we are separated and he's by himself and he's still really having a hard time without any of those environmental influences, then it could be sensory. And that's where, there's a lot of exercises and sensory diet, and you would look to an OT for help and support on that, and you can incorporate that. So really, today, I just wanted to explain why the function of behavior is so important. I think, again, as parents, we tend to just get emotional and get upset that we don't have control of the situation, and we tend to take it personal, and it's not effective for us because they end up reacting to us, we're reacting to them. And I think today's takeaway from my talk anyway is that if you can stop and just look for what they're trying to get, you can help arrange the situation so their behavior becomes more effective for them, and then they're happier and you're happier. So that's all.
Jill, if people are listening to you and knowing that that is a fabulous formula to work through, as I have every time I've seen it, to get started, when can they meet with you? I know you said on your slide there you would have some sessions. So when would you be readily available if anybody was interested to come sit down with you and learn how to get this started?
Okay, well, thanks for asking that. Because my family's here this year, I'm not doing the one-on-ones all day. So what we did is we kind of put a group together tomorrow at 11, because a lot of times we can learn from each other. And a lot of times, especially with behavior, when I hear a scenario, I can sort of take and apply the formula to the scenario, and then when other people hear it, they go, oh yeah, that makes sense. And then if you hear it in enough scenarios, you start to see the pattern, and it starts being a lot easier. So I think it's more effective if we have several families together kind of talking it through. The last way that you can is signing up for a one-to-one through Parent Project after the conference.
Jill, I have a question for you. So Jill is one in a bazillion BCBA, who's amazing, and we need more of that. What is your recommendation for families who probably get a lot of recommendations for ABA, maybe feel a little bit gun shy? So I'm a behaviorist as well, like Jill. She does a lot more treatment though, and there are a lot of people that could help you, but they don't know they can help you. What would you coach parents in doing or saying to get a BCBA on board to be like, okay, I can think about how to help you outside of discrete trial training and other things, but really applying behavioral principles to parenting?
Yeah, it's tough because there are services, right? You can get some of those services through the schools, and you can get them through clinical, and if you have the Medicaid waiver, sometimes you can even get them through the Medicaid waiver. But, for me personally, I learned it. That's how I went back to school and got into behavior, because I needed it, and I needed to learn it. And I think, people think of ABA as the discrete trial, like you mentioned, where we're trading a candy for a response, and we're sitting there for 4 hours doing it. So, yeah, and that's discrete trial training. That's not applied behavioral analysis, which is where my focus is. My focus is real life, on the move, in the grocery store, when they're on the floor. That's when you need to think about, okay, what's the function here? And then you can work with that. So I think of it in much broader terms. I think there's a lot more to this than just sitting there training a behavior, because how do you then relay that into the rest of your life?
Exactly. But a lot of ABA providers are in centers, right, where they only do discrete trial training. That's what they think about. So how do you, a parent here is like, no, I need somebody that's a behavior expert, but you don't know that you can help me because you only do this way. Is there something they could say that it would trigger or tell them
Yeah, I mean, you could also ask for positive behavior support specialists too, because a positive behavior support specialist is broader than just sticking you with the discrete trial person that's going to sit there at the table. And I will tell you, across the country in every single state, so far at this point, we still have PTI centers, which is Parent Training and Information Centers. And most of those PTI centers across the country do offer positive behavior support training, so you can learn it yourself as a parent, and you can train your caregivers and your aides in school and some of the people that are around your kiddo every day.
Thank you, Jill. Your passion is infectious, and it's wonderful. So if you guys would like to meet with Jill in her group session tomorrow, you can sign up on the app, so don't hesitate to do that. Last but certainly not least, we have Denise Gruender. She's going to give us some tips and insightful stuff, so come on up.
Thank you. Thanks so much. Welcome. So I decided I'm going to be an infomercial. I would like to just click on this, first of all, so you can see this. Oh, there it is. It's up there. Practical tips. So my biggest thing is use the people around you. We tell our parents, I own a school for children with special needs, and it's so hard out there because you have ABA people, you have psychologists, you have neurologists. well, who's good? Where do I look? You got to look to each other. And if you ask friends, who are you using? Why? Was it a positive experience? You're going to get a lot of help from the people around you. Ask private schools who they refer to. Ask your school who they refer to. It'll help you a lot. Now, what we've done for you here today is try to make your day-to-day life easier. And if we can, and I'm already losing my voice because we are having children's kids track and corralling about 60 kids down there. We've had a blast. Send them down. But while we're down there, we have an occupational therapist, a speech and language pathologist, little behavior and educational techniques, and all of us deal with sensory. So with all of that going on, it's a loud room sometimes. Tell us what you need for your child. We can put them in a little quieter situation. But if you would like us to take a look at your child and give you some tips, we can pull them out one-on-one and work with them. And we have a little bit of tomorrow to do that, but we're a phone call away and we'd love to help you. So speech and language, OT can both see you, and we have one-on-ones so that you can talk to us. Also, I would love to help kind of create what all they say you're going to deal with. If I can help you one-on-one, it's hard to present to all of you because you have different needs, different ages, different ability levels. So one-on-one with me, if you can't get in with us now, we're pretty sold out, but I'm a phone call away, and everybody at PPMD knows my phone number, and we can match up over the next month when you've settled after the conference. For example, how to make a rule wall at home so everybody's happy, how to deal with a time timer, how to make a magic bag to get through doctor appointments, to get through church, to get through anywhere that you have to sit for a little while, bumpy cushions, make some if-then charts. So, and remember, parents come to me all the time, how can I help make life easier for my child? Well, guess what? You're parenting, you're hugging, you're holding. Remember to say the word no. They go to school and they hear the word no, and they have a total meltdown because they've never been told the word no, because there are babies and they're going through a lot. So right now, practice. Tough love is the best thing we're going to do, and it's the hardest thing you'll ever do. But when you say no to them and you keep a strict, I think I met with like 6 of you today, and some of the things we just said is keep a schedule, keep saying no. Every time you ask a question, you're teaching your child processing skills, right? Every time that you make them sit for dinner, instead of run around and trying to feed them one more bite, you're teaching them circle time at school. You're teaching them to sit in a classroom and to listen. Sitting at dinner is huge. So start thinking about some of the things you're helping them every day by doing all of those things. I'd love, love, love to talk to each of you individually to help with every one of your children and their needs, and to help with your other children. Just that one with Duchenne is hard, but sometimes to incorporate all of our children. I'd love to help you with that. And so if you can come schedule us and see if we can sit down and talk a little bit more. Thanks so much.
Thank you so much for sharing that, Denise. And one thing I want to ask you is if there's people out here listening that are on their second or third child, they didn't maybe need that kind of assistance with their older children, will you still welcome them and bring them in to say, okay, yep, this is my third, like for me, my first one was easy, Brendan, my second one was even easier, and now I know God has a sense of humor because he gave me the third one. So my question is, do you welcome people? Will you encourage people to come see you and say, okay, this works for 1 and 2, but this isn't working for 3. How can I help you?
Yes. Yes, yes, yes. So we want a whole family approach because it is a whole family approach. So anything we can do, first, second, third born child, whatever that is, we are just going to encompass you and try to figure out what's going on in your life. Someone asked me today, so I think my house is a little different. I hear all these other parents, and we don't operate like that. It's okay. That's how you're supposed to operate. And I will incorporate how you can make your day-to-day work for your child.
Great. At this point, we're going to open up the mics for questions, and please feel free to ask our panel anything that's weighing on your mind that's heavy, because as somebody said earlier, it works better when we're all together. So your question is going to help many people and provide answers they're probably looking for as well. So don't be shy.
Okay, so I have a question about behavior, more so at school. After afternoon, there's the fatigue sets in, the day has just been overwhelming for them. My son will be going into 4th grade, so he often get notes from school about times that he's misbehaving in the afternoon, and how can we handle that? What can we do? What can we help the teachers to help facilitate that frustration, that emotional outburst, that happens in the afternoon?
Oh, sure, yeah. So, I mean, really, does he have an IEP? Okay, yeah, we'll talk about it. So, okay, that's okay. 504 IEP, either way, whatever's working at the time. I mean, really, I'm always going to tell you that your relationship with the team staff is number one. That's the most important, even beyond the paperwork a lot of the times, because what's actually in the paper and what's happening on the ground sometimes are two different things. So really, it's about your rapport with your team. And it's about sitting down and being really creative. You have to listen to what they are trying to achieve or what they're tasked with achieving throughout that day. But there's a way to, rearrange his schedule. I mean, we've had young men who kind of do we, well, I don't know if they do we anymore, but they used to do we in like a room with some of their kids, and they'd change kids that would go in there and have a more mellow recess, rather than tearing all over the playground, right? Or maybe they had game time or something so that they could monitor their levels of fatigue a little bit better. Or maybe arranging something a little bit quieter in the afternoon. Maybe he dips out of some of the heavier duty activities and goes and helps a student in a lower grade do an art project or something. I mean, the school can have a lot of creative leverage to change things. You just got to have that rapport to be creative and work it out. But we can talk about it. Come see me.
That's actually really common, especially around that age. I very much agree about being thoughtful with how you structure the schedule. They cognitively fatigue on top of that, and so if there's a lot of heavy academic classes that are harder for him, some kids are better at reading or some are writing or science or whatever. If the harder ones are in the afternoon, get those changed in his schedule next year, probably to have them a little bit earlier in the day. But I have a lot of dudes who need a break after exciting things like lunch in order to transition and have the afternoon not be a hot mess. And so on top of like his class schedule and scheduling in general, and then working with your school, like play with it on the weekend. If you're like, oh, like we do best and we kind of keep it on if we kind of take a 15, 20-minute break every 2 hours, 3 hours. If you figure that out, that's way easier for the school to implement. And then you just do that 24/7, 365. I don't care if it's Christmas and you're going to see family and then Disney World and it's the best day ever, or you're going to a funeral and sad things. Like you keep a consistent schedule because that's just what they need to regulate. And that break can't be like, oh, I'm playing video games and doing things like that activate me, like competition, stuff like that. But we're doing like things like Legos and doing some like sensory stuff and doing some other things. But forcing that physiological shutdown by reducing the stimulus in the environment can be really helpful, because the after lunch thing is really common, unfortunately.
I just want to add just a touch. I'm glad Natalie raised this. 4th grade's a really big leap in terms of what they're usually being expected to do from a cognitive perspective. It's the first year that they're really kind of taking the skills that they've learned and applying them. So there's a lot of attentional demand. That's also an age where I really want to make sure we haven't missed a learning issue, because sometimes that's where it starts to show up. So like if there are reading vulnerabilities or writing vulnerabilities, they may at that point need a little bit more support, just from an academic perspective. So my other question is usually, what are they doing? when they're misbehaving, and to also try to even reframe the misbehaving as a response to a difficult circumstance. Like when I hear that, I immediately say, okay, what was to sort of Jill's point, like what was the trigger? What were they being asked to do? Because that's usually a response to, I'm having a hard time navigating these circumstances. And so then I want to know what the circumstances are to try to get to the bottom of that. And that's when an evaluation can also be really helpful around learning issues too. But if it's not that, then sort of restructuring the day so that some of those heavier cognitive things go up front can be really helpful. Yeah.
One last thing. We have notes that go from school to home and home to school, like a reward chart at the end of the day. So if he got the star, if he got the check mark, then maybe at night he gets dessert or he gets a later bedtime or whatever it is, just to motivate us. If the behaviors are going on at home, then if they get a great check from mom, they come to school, then they get some kind of reward at school that they don't have to sit in the front of the classroom or whatever they don't like, so that either way, someplace they're going to have meltdowns, and so use a note to and from school. It's what we try.
Those are great suggestions. And don't be afraid to ask, everyone. Don't be afraid to speak up. Sometimes the school doesn't know what they don't know, and especially if this is the first round that they're dealing with, it's okay, because what you're putting out to play might benefit additional students. So those are a great idea, guys. Thank you. We'll go here in the middle.
Thanks. This is a question specific to Oregon, but it also might relate to other states. Oregon is a great state to have intellectual disabilities, and somehow Duchenne muscular dystrophy is not included as a developmental disability qualifying diagnosis. But then I hear a lot of this relatively new research about what's happening in the brain, and I wonder, is there material that's available to present to these eligibility specialists, or do we know more about all the developmental delays and impact, and how can we get that information more broadly understood?
It's a really good question. I mean, I think if you haven't already, I would sort of start with a neuropsychological evaluation. And, while we've been sort of the neuropsychology community sort of trying to kind of push this idea about a neurodevelopmental disorder due to dystrophinopathy, even within any sort of these labels, every child's still an individual, right? So I could fill this room with kids who've been diagnosed with ADHD, and every one of them is still going to be different, right? And the same thing is really true of developmental delay and intellectual disability disorder as well. I think what I would probably, from a practical perspective, recommend is having a neuropsych evaluation done, where they document sort of the cognitive, adaptive, and
Yeah, we've done that, and we are this far below the qualifying number.
Sometimes that will, you should jump in here too, but sometimes that will, it depends on we can talk about this too, but your child's age may matter a little bit. So sometimes there are kids who are sort of skating the line in sort of middle school years, but the adaptive difficulties become more prominent when you start to get into the transitional age, especially when the physical demands are higher, and sometimes that's enough to tip it, if that makes sense. Yeah, I'm curious what else you have to say.
I was just going to add that, how old's your son?
He's 16.
Okay. So it does work better with the younger guys that have speech delay, but a lot of times, because you're that close on the neuropsych eval, the school, a lot of the states, I'm pretty sure Oregon's that way, I know a lot of the states will take a school full psychoeducational eval. And so sometimes, depending on what their responses look like to that test, it could potentially reach and meet one of the categories. So I just wouldn't rule out a school eval either, because they're separate, and you get to kind of choose which one you're going to give them when you go to apply.
We've done both, and he's right here.
Okay.
These are recorded, and so I would encourage you to go in and pull the slides that I presented with some of the information. Yes. I would take that, because what we are saying is, yes, like this is involved in development prenatally, which means it's a neurodevelopmental condition, just as a muscle condition. I don't think any provider in here would not say, yeah, we agree with that. It just takes a stupid amount of time to change change these things within the DSM and some other places. So I would take that, and then I would take your report and say, these are the areas where, maybe we have a little bit more time, trouble emotion regulation has a little more time, or harder time, like for the frontal lobe functioning. And lo and behold, we have this data here. And so I think if we put this together, and that would be likely what we're all going to need to do to shift this needle to get better coverage and parity along with what we are understanding this to be a neurodevelopmental condition. I mean, there are a lot of physicians out there that aren't in this space who don't know that dystrophin affects the brain, right? And so, like, if they don't know it, the insurance companies sure as hell don't know it. Also, do they care? I don't know. But we need to make them care. And so I think being loud and advocating and trying to finagle it, and then if it's successful, be like, I figured out how to do this. This is what you guys do. And, like, blasting out and working on getting things shifted. And that's, like, a kind of a cop-out because we don't have a good way to do it. But we have those articles. We can get them to you. So you have them at least to be like, here you go. Here's data. Like, figure it out. I figured it out. Read it and make sense of it. Because it is, Natalie Dorian's research is complicated, but.
Thank you.
Yeah.
That's a great question. Thank you so much. We'll head over here to you.
Hi. Yeah, so, well, let's see. I'm asking some question. I kind of think I could be paranoid or just there's no correct answer. But okay, I'm just gonna try it. So we have our 3-year-old over there. He's making a lot of noise, but we're having some I guess concern. Well, especially for me, I guess how do you determine like is it basically is he just is that he's bad behavior and he's like terrible emotion eruption? Is that because of the fact that he's a Duchenne and which implies that somehow he will carry over throughout his life, or like he's just being a bad kid and we just need discipline and yeah, it's hard to sometimes for me it's hard to gauge because like sometimes maybe I should show some sympathy to it, but sometimes it's like, you know what? Maybe I should just discipline this guy. Yeah, it's sometimes hard to gauge which one that is, and also same thing happened with learning and recognition, I guess. I mean, on the whole, he's doing good, but just some specific area, especially something like color and shapes, and I mean, I know every case is different, but just want to know like to what points should we consider, okay, that some learning problem could be caused from Duchenne, and that might be something we need to look out for, or instead of he just a little bit slower, it's fine, he'll grow out of it, something like that.
So I'm going to start off by saying, regardless of is this just neuropathy driven or is my child choosing to engage in poor behavior, it doesn't matter. And it's important to address it and to discipline it, although it might be harder for them, right? We're not saying, I expect you to be able to regulate at the same degree as maybe another 4-year-old or a 5-year-old, but I do have some expectations on your behavior, right? And I'm gonna help you through it, right? And we're gonna do this together, but it's not like I have no expectations. So when we're talking about dystrophin in the brain and these things are challenging, it's not to say they can't do it, right? It's just harder, it takes more effort, it takes longer to learn, it's harder on you all. And so it doesn't happen in from the same sort of activity-dependent, direct and non-direct learning sort of modeling ways. You have to be a little bit more intention with it, right, and couch that a bit so their people understand what they're doing, right? So it might take them, they will catch up down the road, but we don't want to wait till then to support them in developing that skill. So sometimes it's about modifying that, right? So if we're a couple years behind frontal lobe-wise and we're in 3rd, 4th grade, we can't be expected to regulate like another 8, 9-year-old. We might be more like a 6, 7. So how do we as adults work with that and put expectations on ourselves to have patience and whatnot while still addressing and shaping adaptive behavior, but also for the school and the other places, right? Because we want to optimize the learning, and what we know are these boys can learn. It just might be a little bit harder, take a little bit more effort on their part and on our part, right? And take a little bit more time. But the expectation can't be they can't do it, right? Because then we don't address it, and then we find ourselves with the most adorable little monsters running around you'll ever see.
Yeah, that's something I'm afraid of.
And if you go see one of a psychologist, a neurologist, an occupational therapist, they will give you great guidance on how to start working down the path.
Okay, thank you.
Thank you guys so much. I would love to keep this conversation going because it is so powerful and you guys are so intelligent and so passionate about what you do, and we can't thank you enough for sharing that with everybody today. Please make use of these wonderful ladies. They said find them in the hallway or sign up for their sessions. You can find them and definitely keep this conversation going. Thank you so much for your time today, and we are going to pass over the microphone to Christy Lewandowski. She is going to talk to you guys about nurturing your mental wellness.